Good afternoon, everyone. Thanks for being here with us. I'm going to, in a minute, introduce the fellow panelists here, talk a little bit about that film series, and then give a little bit of background to the conversation that we're about to have. So first, I want to introduce the star of today and the film, Chanel Porchia-Albert from Ancient Song Doula Services. Don Godbolt from the National Partnership for Women and Families. And Jerilyn Church from the Great Plains Tribal Chairmen's Health Board. So the film that you saw today, Giving Birth in America, New York, is one of 7 films in a series that we've done over the past few years that looks at what are some of the issues causing the maternal health crisis in the United States, but also highlights what are some of the solutions. How can we begin to address what we know is a human rights crisis in this country? Because we know that not only is the system failing our mothers and our babies, but that we have examples that need to be brought to scale to better serve all of our communities because of the wonderful work that is being done in small pockets all around the country. How do we make that system, how do we bring that to bear system-wide? So these films highlight the stories of pregnant and childbearing individuals and the care providers as well, in order to bring faces and voices to the statistics, to make sure that people can really see what these issues are, what is affecting people in their childbearing care and processes and experiences. And as we start the discussion, I just want to give a little bit of context to what we have been thinking about as really pressing issues at the moment. Because for a long time, maternal health has really flown under the radar as in terms of the importance of the issue in the United States. And I think that we've seen growing interest and concern over the issues and growing action. So over the last 5 years or so, I think we've seen a huge difference in how the issue is being addressed, but primarily that action has been taking place on the clinical front. So we've seen really innovative and passionate physicians, midwives, and folks in the public health sphere who've been focused on clinical solutions. Things like developing safety bundles, so guidelines to help address the leading causes of pregnancy-related complications and deaths. And we've seen a growing interest in and dedication to and funding of maternal mortality review boards at the state level so that states can start to better identify the causes of death and complications and then hopefully meet those needs and address what those problems are. But what we've also seen is that those solutions are necessary but not sufficient. They're not really moving the needle. And so we need to keep moving on that clinical front, but we really need to up our game and drive attention and action on a systems level across the board, with policymakers, with addressing access to care, and in the public health sphere, as well as on the clinical side. And I think that to focus too heavily on the clinical misses the fact that we know what the solutions are. We know how to save lives. And so a lot of the issue really is finding and creating and driving the political will to bring these solutions to bear. one of the things that I think will come out in this conversation, and I think certainly comes out in the film, in addition, is that the issue of people's experience of their care, how they are treated, whether they are treated respectfully and with dignity, or whether they feel subject to bias and discrimination or mistreatment, is not just something that affects their experience of care. It is something that affects their physical health, their mental health, and frankly is an issue of life and death. And I think that's something that we really need to focus on. So in the last few years, I've been part of a team that developed and fielded a large survey in the US, the first survey to specifically focus on mistreatment, disrespect, and abuse in childbirth care in the United States. It's something that has gotten more attention globally than in the US, but it's now getting increasing attention here as well. And I think that the results are really shocking. 1 in 4 people who gave birth in a hospital in the US reported experiencing one form of mistreatment in that care. And for women of color, that rises to 1 in 3. 1 in 3 women of color report being mistreated or being treated with disrespect as part of their prenatal care or childbirth care. And that I find shocking and appalling. And some of the types of mistreatment, the two most common types of mistreatment were that they were ignored or refused help in a timely way, or the care was withheld, treatment was withheld, or that they were threatened with coerced treatment or threatened to have treatment withheld if they did not comply with the physician requirements. And this gets us back to why this is so closely related to healthcare outcomes. In a separate study in California, the Pregnancy-Associated Maternal Mortality Review found that healthcare provider factors were involved in 81% of pregnancy-associated deaths. 81%. And the most common factor was delayed response and ineffective care. So what we see is that women are reporting mistreatment in enormous numbers, and that in fact, that mistreatment is a factor in many of these preventable deaths. So I want us to keep that at the forefront of our minds as we talk to the panelists and think about what we all can do to change and address the maternal health care crisis in the US. So Chanel, can you talk with us about how you decided to start this program and why you think that Ancient Song Doula Services model is one that should be replicated?
Okay, so first let me say good afternoon. Are you awake? Did your cupcakes give you some energy? Good, I just want to make sure. So I got into this work because I'm a mom. And so I'm a mother of 6 children. I have an 11-year-old son. I have 10-year-old identical twin daughters. I have a 9-year-old daughter. I have a 3-year-old daughter, and I have a 2-year-old son. Yes, you can close your mouth now. I started out on my journey, I think most people, right, where you become pregnant and you're giving all these tools to think about when you don't want to be pregnant, but when you do become pregnant, you have no idea what to do. It's like going through college, right? You remember like your junior year of college, you start to get all of these different applications in the mail, and you're sorting through them, and you're wondering like, okay, so but what does all this mean? And I think that my journey was much like that. And so as you saw in the video, which was interesting, I started to cry because it's, my babies are in there. And my children are the catalyst for everything that I do. My children are the foundation for the work and for the reason why I'm able to sit here on the stage right now and be able to talk to all of you. I'm just a regular person who went through a regular experience of having access to care. I started out as a commodities broker. It sounds more highfalutin than what it was. I had access to go to any OBGYN I wanted to go to. I had private insurance. I had all of the things, right? All of the things that you think that you're supposed to have when you're getting ready to become a parent. And I was going to care and realized that the care that I was given, although it was from a person who looked just like me, she was just cold. She was sterile. She had no vibes. You know what it means? Like when you meet somebody and they got energy and you're like, you've got vibes, right? Or you're like, I'm gonna stay far away, right? And she had no vibes. She had no energy. Like every time she gave me a sonogram, like my son was in utero, like, nah, sorry, right? He would like dip and dodge. And so I listened to that, and I remembered that I happened to be in Union Square, and so anybody who knows the history of New York, Union Square is like the focal point or the catalyst for change. It's a place where advocacy has happened since the early 1800s. And I happened to come upon a Natural Birth Expo, and I saw all this information, and there wasn't anybody who looked like me, and then I happened to see people who looked like me, and I was like, oh shoot, you's a black woman. And she happened to be a midwife. And I said to her, I said, you know, realistically speaking, I said, I have to just be very honest. I said, when I thought about midwives, and in particular black midwives, I thought about it always in a historical context. I thought about it in a way in which where we read books and we're like, oh yeah, that's what happened back in the day, like that's history. And she's like, no, we exist. And so I said it well clearly, right? And I held on to this information for 2 years, and then I happened to meet my husband in it's a typical Brooklyn story. Happened to meet my husband on Nostrand Avenue in a health food store buying tofu. Yes. And I saw this man standing there, and I was like, oh my goodness, he looks so wonderful, and you know, look at his teeth, he has nice teeth. You know, because women, we go for teeth. Either teeth or we're looking at your shoes. So if you didn't know that, make sure your teeth and your shoes are correct, right? And so I go outside, or I say to myself a little prayer, and I'm like, okay, Most High, if this is supposed to be, then he'll be outside. And I go outside, and I don't see anybody, and I'm like, what the heck, like for real? And then I hear someone call me from across the road. He's like, excuse me, miss, excuse me. And he talks to me, he's like, can I take you out for tea one day? And I was like, where's this man from, another planet? Like, what man do you know says, can I take you out for tea? Actually, he's not even from this country, so that's why. And long story short, you know, we ended up pregnant, and I remembered I had all this info, and so I went onto MySpace. Yes, I am dating myself, right? This is before it was a music platform. Went onto MySpace, found that midwife, had a wonderful home birth experience. I did everything that, you know, crunchy people are supposed to do, right? You go, you walk through the park. I took my shoes off. I walked through the park in New York with my shoes off, right? I hugged trees, I came back, I listened to music, I ate great food, and I had my baby. And it was the most life-changing experience that I could have ever had. And so 3 months postpartum, I went and I took a doula training, and it changed my life. And I left my job, as you can see, and my husband was like, what do you want to do? And I was like, yeah. And so I left my job, and it started from just the sheer fact of starting to go to births and seeing the ways in which people were treated. Seeing long wait times, seeing individuals not listened to, seeing all of the attention being put on the doula and not the actual pregnant person who was sitting right there before them. Or going to a birth and seeing someone have child protective services used as a tool to get them to comply with a medical procedure. Or seeing children who are illegally drug tested or parents illegally drug tested without their consent, and then see children taken away from them for no apparent reason. For seeing individuals who were trying to advocate for their loved ones have security or police officers called on them and then being escorted out of the hospital. And I said, this can't be normal. This is not normal. This is not something that normally happens. And then having private clients and seeing the ways in which they were treated. Having, would you like anything? Do you want something? How can I help you? And so really wanting to bring the humanity back to us really seeing individuals. I think that we have lost the essence of who we are as people, that we no longer see, we don't hear, and we choose not to love. We choose to not see individuals, and we choose to not connect in ways because sometimes we think that then somebody is going to see who we really are, and then that makes us vulnerable. But the essence of what it is that people really want to know that you see them, that you hear them, and that you genuinely care about their well-being. And so I started this program. I didn't know what the heck I was doing. I'm gonna just be real clear. I'm not gonna say that I had this roadmap for healthcare because I did not. But what I did have was a drive for change and to connect with individuals who were actually on the ground, who were public health workers, who were nurses, who were midwives, who were in the field every day, and I talked to them. And I asked them questions, and I was really humble about saying, can I carry your bags and get to know and learn about the things that you are doing every single day? And I think that the model can be replicable because of the simple fact that if you are an individual who is seeking to create change, then you can do it. And then you may say, but I'm in a place where my voice isn't necessarily heard over all of the other voices. It only takes that one day and that one time that you talk. And you may get her told no consistently over and over again, because I did, and that's fine. But it's nothing that you cannot do. But it first starts with you. It first starts with you taking an active responsibility for saying that I want to see more and I want to do more for someone else other than myself, because I want us to be in a world where we see each other, where people genuinely care about the well-being of one another. And I think that within healthcare, when you decide to go into this work, you do this because you want to do better. You saw something, you wanted to make a change, and so you actively said, I'm going to go into this profession so that I can do that. And then somewhere along the line, because of all of the red tape and the systematic oppression, and because of the racism and because of the trauma that you experience yourself, you get disillusioned in the fact that you can actually do it. But you can. But it takes you to stand up for truth and rights. It takes you to choose goodness over something else of other. It takes you to take the initiative to say, even though I may be scared and I don't know what I'm doing, I'm going to do something, because if I do nothing, then this will continue to perpetuate itself on a consistent basis every single day. And so if you want to make change, it starts with you, really and truly. That's the replicable model. This is not something where you are gonna you can read something, yes, and you can read the data, and we have statistics and all that stuff, and I can read to you a bunch of numbers. But the essence of it is actually you being able to connect with someone else on a human level. That is what changes something, not the actual model. The model is just a format to get you to understand what some of the steps are. But you as the individual have to be the one to make that change. Does that make sense? I can't hear you. I don't know if you're ready. Because I need to know that when you leave here that you're actually ready to make change. Are you ready?
Yes.
Okay, that sounds a little bit better. I'm gonna turn it over to my peoples over here.
Thank you. So, Dawn, can you describe the current state of maternal health and any recommendations that you have to address disparities and bias in the maternal health care system?
Sure. So I want to start by thanking Chanel for sharing her truth, her stories. I'm going to read you a bunch of statistics, okay? Chanel is bringing us that human connection, the real life, on the ground stories that quite frankly have helped us to elevate the issue of maternal health. So you all have heard that the United States has an increasing maternal mortality rate, that when we compare ourselves to other high-income nations, that we are falling behind. When we disaggregate this data, what we see is that many of the maternal health outcomes, the poor maternal health outcomes, are driven by disparities between white and Black women and white and Native American women. And so compared to white women, Black women are more likely to be uninsured, more likely to face greater financial barriers to care, and they're less likely to have access to prenatal care. 3 to 4 times more likely to die from pregnancy-related complications or during childbirth, more likely to experience preventable death during childbirth than white women. more likely to have complications, more severe complications. The onset of complications occur faster and sooner than white women, and these complications like gestational diabetes, preeclampsia, hemorrhage, they can be life-threatening, they can be severe, and often the recovery period is longer for Black women than white women. I'll also underscore that Black women are more likely to receive a lower quality of care. 75% of Black women give birth at Black-serving hospitals. These are hospitals that serve primarily Black populations. These hospitals are under-resourced, and they often have higher rates of maternal health complications, and they perform worse on outcome measures. On 12 of 15 outcome measures, including trauma, non-elective cesarean birth, and mortality. And then one other thing that I want to underscore is that Black women cannot buy or educate themselves out of the maternal health crisis. This is something that we experience despite our education levels, our access to insurance, or our income. In fact, one report in New York found that a Black woman with a college degree is more likely to die during pregnancy or childbirth than a white woman without a high school diploma. I also want to again say that these disparities are seen in the Native American community, that Native American women are more likely to live in hazardous conditions, experience food insecurity, and lack access to health insurance. The Indian Health Services is chronically underfunded, and this is where most Native American women receive care. As a result, American Indian women are less likely to have access to prenatal care, and when they do, they are 3 to 4 times more likely to receive prenatal care during the 3rd trimester than white women. Oftentimes, the facilities that they go to receive care do not have the resources that are needed to increase your better maternal health outcomes. And so also American Indian women are more likely to have maternal health complications, I've already named a few, and more likely to experience discrimination. Black women and Native American women are also subject to weathering. This means our bodies age faster due to the allostatic load that exposure to chronic stress over the life course. I'm talking about discrimination, socioeconomic disadvantage, and racism. This exposure makes pregnancy riskier for us at an earlier age than white women. The healthcare system is also steeped in racism. There's a history of racism in both the healthcare system, but particularly in gynecology. The father of modern gynecology perfected his technique on enslaved women without anesthesia. Many of the adverse maternal health outcomes that we see can be traced back to the historical trauma of systemic racism, colonization, genocide, forced migration, reproductive coercion, and cultural erasure. Particularly for the Native American community, forced sterilization and infant separation policies make it difficult to form trust between clients and providers. And so I understand that was a lot. I cannot underscore how dire the maternal health system, healthcare crisis is for Native American and Black women. But the CDC says that 3 of 5 maternal health-related deaths are preventable. So there are things that we can do. I'm gonna give you a quick list, 5 recommendations that we have. The first is to use a reproductive justice framework when approaching maternal health care. This framework was developed by Black women-led organizations like Black Mamas Matters Alliance and Sister Song. The framework advocates for the human right to maintain personal bodily autonomy, to determine for oneself whether and when to have children, how to have children, and the right to parent children in safe and sustainable communities. 2, We need to expand and maintain access to health coverage. Quickly, states who have not expanded Medicaid need to expand. Second, we need to extend Medicaid to at least 1 year postpartum. Typically, coverage ends at 60 days. That's not long enough. 20% of maternal death cases occur 43 days to 1 year after birth. So we need to cover those women for at least 1 year. 3, we need to expand protections, workplace protections for pregnant workers, and we need to expand paid family leave and medical leave programs so that women can take the time they need to care for themselves and their children. 4, we need to increase access to comprehensive reproductive health care, including contraception and abortion care. Reproductive health care is not needed only during pregnancy. Reproductive age is 15 to 44. That is a long period of time in which women may need access to care. So we need to expand coverage. And then my last recommendation is to increase access to community-based models, not unlike ancient song doula services. I had the pleasure to interview 4 different community-based models, and what I found is that these models fill a gap in the healthcare system. They primarily serve low-income women and women of color. They provide care that is predicated on choice and autonomy and respect. They base their model in a patient-centered approach, and listening to women is integral to their care models. And to support these community-based models who are doing this incredibly important work, we need to provide sustainable funding streams for these organizations. We need MCOs to reimburse these providers at a sustainable rate. We need CMS to give guidance, clarifying and encouraging reimbursement for community-based perinatal health workers. At a living wage. At a living wage. Many of these organizations, they effectively harness community power. Aza Nadari from Amatoto Village, she said, "The women we serve are the women who serve." So she pays her staff a living wage to work with women who otherwise would have adverse maternal health outcomes. So we have to make sure that the reimbursement rate is sustainable and a livable wage. And then I think I'll pause there, Nick.
Can I add?
Yes, please.
But I just want to add to that as well, for all of the policy people, health policy people who may be in the room, that you also, when you are thinking about policy, you want to make sure that you have community members as active stakeholders within the composition of any kind of legislation that you are thinking about passing, as well as accountability measures to hold systems that are providing disrespectful care and inhumane care at birth and through the reproductive life course to individuals, because we can no longer have policies that no longer hold a higher standard of care.
Absolutely.
Thank you. Thanks to both of you for that and for adding that, Chanel. Dawn, you did a really great job of talking about the disparities, both with regard to Black and African American communities and also raising the issue of Native American communities, which historically have really been left out of this conversation, despite the fact that American Indian and Alaska Native women have nearly as great disparities in outcomes in this area as do Black women. So thank you for highlighting that. Jerilyn, can you talk specifically about how maternal mortality and morbidity affect your community and what you see that is working on the ground?
Sure. Within our Native communities, historically, women were held of higher stature. Most of our tribal communities were matriarchal. So to see some of the disparities unfold, to see the maternal mortality and morbidity rates where they are counterproductive to what has been culturally and historically held by our communities. What that's done is, as it's highlighted for us the impact of historical trauma. It's highlighted for us the impact of colonizing our tribes and our tribal communities. And it's reflective of historical policy that really has devalued women and mothers. What we've done in the Great Plains region is our organization holds one of the longest standing Healthy Start programs. We were one of the original 15 Healthy Start programs that began in this country. And what that's allowed us to do is bring in the aunties and the grandmas that were the original doulas and midwives, and to help mothers and to help young mothers in particular reconnect with those traditionally cultural values that that were once the foundation of our communities. What's fallen short, however, is the funding that is available. So in our region, we serve 18 tribes in North Dakota, South Dakota, Nebraska, and Iowa, but we're only able to provide those services to 6 of our communities, and those communities are the communities that have the highest rates of infant mortality.
Thanks. So before I go back with you, I think maybe I'll ask a second question coming back in this reverse direction. So Jerilyn, could you talk about what some of the emerging issues related to maternal mortality and morbidity are in Indian country, what you're seeing?
Sure. One of the most recent issues of concern in our communities is the realization of murdered and missing Indigenous women. Across the country in 2018, there were a total of 506 American Indian women, many of them mothers, who were either identified as missing or murdered. Out of that group, there were about 300 of them that were actually murdered. And out of that group, almost over 30%, there had been no one identified or no one held accountable. And that rate is growing. And it's only been in the last year or two that Indian country has begun to say no more. We cannot, we can no longer allow for our mothers, our sisters, to be devalued. And there's not only a crisis in terms of murdered and missing Indigenous women, but even the data behind that.
Yeah.
What we see again as a way to begin to reclaim the sacredness of our women is to, again, use and look to culture as healing. There's a phrase in many of our communities that culture is healing, that traditions are healing. So we need to address the issues through traditional Western agencies and systems, but in order to really embrace our families and lift them, it has to come from within, and it has to come from reclaiming those traditional teachings around sacredness of our women and sacredness of family and reinstill those values. So that work needs to be done by our own people and with those traditional teachings alongside.
Thank you. Dawn, you've talked about the importance of providing more training to healthcare workers and expanding access to postpartum care. How can those strategies help to improve maternal health?
Sure. So when we talk about trainings, there's a couple of different things I think of. One is implicit bias training and going beyond implicit to explicit anti-racism trainings. So I think it's very important to provide care that is culturally relevant and appropriate, as Jerilyn has said. Indigenous communities and African American communities have very long, rich histories of birth care, midwifery care, and so getting back to sort of those cultural roots are very important. And I'm sorry, providers being able to provide care that women want and need. And so a part of that is just training, trying to unlearn the biases and the stereotypes that we have, because those color the interactions that physicians have with their patients, right? When you are, as Chanel said, right, she felt uncomfortable with her provider, and that influenced her treatment, her choice of her plan, her action plan. And so we need to make sure that providers understand the population that they are providing care for. And then the other type of training I'm thinking of is diversifying the birth worker field. We can create pathways that expand access to both midwifery and doula care and OBGYNs. We can prioritize training programs that center these sorts of competency programs, or center acknowledging the historical trauma that has been done to women of color in this country.
So we have a lot of advocates in the room today, so it would be great to hear a little more about advocacy. What role, Chanel, does community organizing and advocacy play in your work? And what advice would you give? How can the advocates who are here with us today help tackle this issue in their own states and communities?
So I have personally always been an advocate in my life. I grew up in a household that was of starch advocates and policy folks. I worked my first campaign when I was 13 years old. I don't know if that was legal, but that's what I was doing. But Ancient Song, in and of itself, we have worked towards addressing the unintentional consequences of Medicaid reimbursement for doula coverage within New York City, New York State. And some of the groundwork for the policy work that we did was really to mobilize individuals on the ground floor and really take a grassroots approach to talking to people. First, educating them around how does policy even come into fruition? How does legislation even come to be? And them understanding that if you have an idea, you can bring it forth to your representative within your district, and you can present that. And then going through specific models of care. So it really started with education. It really started with us. We went all throughout New York State, from rural New York down to the city, and met with doulas and birth advocates throughout the state to really talk to them, to listen to them, to hear their stories, because I understand that what happens in my home, and when I say my home, I mean Brooklyn, and what happens in like Syracuse is two totally different things, although it's in the same state. And so really going to where the people are and listening to their voices and having one-on-one conversations and genuinely listening, but not just listening for the sake of saying, oh, I was there, we saw, we came. right? But actually taking those recommendations and really putting them, pen to paper, and then connecting with other advocates. We got them involved. We showed them, we did advocacy trainings, lobbying trainings, showed them how to do the work themselves so that they could get involved themselves. It's not just about an organization coming and saying, oh, hey, here, we're gonna do this. It's about teaching the people who live within those communities how to get involved one-on-one. And I think that that is something that we've been able to do really, really well. So well that people have called upon us to ask questions nationally. Working alongside with Every Mother Counts and NAN specifically for years, we also, in Village Birth International, which is another organization that is in Syracuse, New York, we were able to create a report called Advancing Birth Justice, Addressing Racial Disparities Within Healthcare. And the premise of the report was really to lay the groundwork of Medicaid reimbursement for doula services, to propose equitable models for reimbursement and in those services, but also to talk about the different types of models of care that currently exist within various different communities, not just within the state of New York, but all across the nation. And so that has really kind of sparked a bigger, broader conversation on what does it mean to have Medicaid reimbursement for holistic care services, because we understand that in doing the work, we don't want to lose the essence of what it means to connect with someone, right? We don't want it to get watered down to the point where it becomes where it's just a checkbox in the work that you do. You're like, oh yeah, see, I went through that. I talked to them, I smiled, we're good, right? Understanding that it's more than that, it's really, truly, and I can't emphasize this enough, it's about human connection. I think, I guess I'll be 41 years old this year, and have gone through various different ages of technology and seeing the way in which, we went from your cell phone was the size of a refrigerator to now your cell phone is small and you can basically do all of your work on that if you had to, like a computer. We've lost the essence of human connection. We've lost the essence of like, what does it mean to connect with someone and really hear them and know that they genuinely care. And that's what people want to see. And so in the advocacy work that you're doing, when you're connecting with people, you're meeting them where they are, not where you expect them to be. Right? You're having those conversations, you're educating, and not educating where you're telling someone what to do, but you're learning, and it's an equal exchange of ideas, and it's humble. It's humbling not just to the person who is providing the services, but it's also humbling to the person who is receiving them. And so then there's reciprocity, and people don't feel like you're just taking and taking and taking, and you're not giving anything back to them. And I think that in any kind of advocacy work that you decide to do, it is really, really important to connect with people on the ground level and ask them, what do you want? What does community need? And understand that that is ever evolving and changing. Trying to create a platform that is just linear and it never changes is not realistic, because you change. You changed your clothes this morning, didn't you? Right? You didn't wear the same thing you wore yesterday. You probably didn't wear your hair the same way you had it yesterday, right? And the way you felt changes from day to day. So understanding that it's not a one-time conversation, it's something where you have to consistently be talking to people and interacting with them on a daily basis to really, truly understand. Because I know how it can be easy to, like, when you're in an office, get disconnected from folks, but go outside. Like, go outside and talk to people. Ask them what it means to them to be able to have equitable healthcare services. And when I say that, I don't just say that for maternal health. I mean that on the level of when you go to the dentist, when you go to the pediatrician, when you are, going to the foot doctor, right? Like, ask these questions. Ask questions. It's important for your own personal well-being, but then teaching other people to do the same thing. And I think that that is the start and the focal point of any good advocacy method.
Thank you.
Thank you.
So we have just a couple minutes for a question for each of you. Jerilyn, can you talk about what role IHS and/or Medicaid have in addressing this issue of maternal health?
So Indian Health Service really has three pillars in which healthcare can be delivered in our communities. One is direct service, which is federally funded and federally managed hospitals and clinics. The other is tribes taking over management of their own healthcare facilities through a contract or compact. And the third are urban Indian health clinics that are in about nearly 40 communities that are not on a reservation. And what has been a challenge for Indian Health Services, was mentioned before, is chronic underfunding. And when you have a system that is underfunded for a long period of time, for a number of years, you can continue to prioritize direct care, which is usually the case. Underfunding is usually around 50% of need. And after time, pretty soon the infrastructure begins to fall apart. Some tribes have the means and the resources to assume management of their health care. And the value in that is that they take the resources that are there for, that are appropriated through Congress for Indian Health Service, but they can also then look for other means of funding to augment that. And urban Indian healthcare is probably the smallest and usually the most forgotten because there's only about 30 communities. So what we find ourselves doing is perpetually educating and advocating. The challenge we have with that is that most reservations and tribes are in only about 32 states. So states that don't have tribes are usually an afterthought. The other challenge we have is that we're the smallest portion of our population, 2%. And I often say that that number is a reflection of the near success of genocide of this country. So for opportunities like this to be able to speak with other healthcare advocates, it is very much appreciated because often we're preaching to each other and we're singing to each other. So I would say, you know, remember the first Americans in your advocacy work. When you're there to advocate for our Black communities, remember, you know, the American Indian brothers and sisters in your advocacy as well.
Thank you. Well, we're almost at... We're almost at the end, and I feel like that was a wonderful last word for you to leave us all with. I think that's sort of that big picture advice, recommendation, request, demand that we all need to keep in mind. Do you have just a few last words, each of you, in our time?
Very few seconds. I just want to uplift a few pieces of federal maternal health policy that need championed, so bear with me. The Mamas Act, the Moms Act, the Mommies Act, the Healthy Mom Act, the Rural Moms Act, the Helping Moms Act, the Quality Care for Moms and Babies Act, the Babies Act, the Maternal Care Act, and the Excellence in Maternal Health Care Act.
All right now.
There's a theme.
Yeah, exactly. I will leave you with something where I want you to do it with me. Take a nice deep breath in. Slowly exhale. Nice deep breath in. Slowly exhale. And I want you to repeat after me. You are seen.
You are seen.
Or I am seen.
I am seen.
I am heard.
I am heard.
And I am loved.
And I am loved.
I am seen.
I am seen.
I am heard.
I am heard.
And I am loved.
I am loved.
One more time. I am seen.
I am seen.
I am heard.
I am heard.
And I am loved.
And I am loved.
When you know you are seen, you are heard, and you are loved, then it becomes easier for you to see people to hear them and to love them too. Thank you very much.